The third type of the anticholinergic agents are those that block the neuromuscular junction. So they are called the neuromuscular-blocking agents. They block the neurotransmission of a cholinergic neuron between the motor neuron nerve endings and the nicotinic receptors present at the level of skeletal muscle. The neuromuscular blocking agents are agents that possess the same chemical similarities to acetylcholine. They are also clinically useful during surgery. For example, they are used because they facilitate what we call tubular tracheal intubation. And the tracheal intubation is a process used to maintain the airways opened, or it is used to serve as a conduit through which to administer certain drugs. They are also useful because they provide a complete muscle relaxation at lower anesthetic doses, allowing for more rapid recovery from anesthesia when the drug is stopped, and they are reducing post-operative system respiratory depression. The neuromuscular blocking agents are classified into two types: those that are depolarizing agents and those that are non-depolarizing agents. The depolarizing agents are usually of short-acting mechanism, such as the succinylcholine, while the non-depolarizing agents are of three types: the short-acting ones, the intermediate-acting, and the long-acting. Example of short-acting, you have the mivacurium. The intermediate-acting, you have the virocurium, mercurinium, and the long-acting, you have the pancurinium. The non-depolarizing blockers are known to be competitive blockers. So they compete with the acetylcholine to bind the nicotinic receptor present at the neuromuscular junction to block it. The first drug known to make this blockade is the curare. The curare was then followed by another drug called tubocurarine. And the tubocurarine later on was removed and replaced by other agents with less adverse effect, such as the cisatracurium, pancuronium, rocuronium, and zicuronium. Those neuromuscular blocking agents have significantly increased the safety of anesthesia, because if you know, less anesthesia in this case is used to produce muscle relaxation, then allowing patients to recover quickly and completely after their surgery. The neuromuscular blockers should not be also used to substitute for inadequate depth of anesthesia. What is now the mechanism of action of non-depolarizing agents? So here we're gonna distinguish between two cases. When they are given at low dose, their mode of action is different when they are compared to when they are given at high dose. At low dose, they competitively block the acetylcholine at the nicotinic receptor. And as you can see, for example, you have the rocuronium is a non-depolarizing agent. When it is provided at high concentration, higher than that of acetylcholine, then it will recognize the nicotinic receptor at the neuromuscular junction, pulling out the acetylcholine and then blocking the sodium channel, thereby inhibiting the influx and entry of sodium inside the cell. So they compete with acetylcholine at the receptor without stimulating it, thereby preventing the depolarization of the muscle cell membrane and inhibiting then the muscular depolarization and contraction. Their competitive action also can be overcome by using other drugs of cholinesterase inhibitors type, such as neostigmine and indrophonium. And it is usually known that anesthesiologists employ this strategy to shorten the duration of the neuromuscular blockade. At high dose, the non-depolarizing agents can block the ion channel at the motor endplate. Remember that the motor endplate is the synapse, that it is between a presynaptic element and the postsynaptic element, which is the muscle itself. And this non-depolarizing agent, when it is given at high dose, it produces a weakening of the muscular transmission, thereby reducing the ability of the acetylcholinesterase inhibitors to reverse the action of those non-depolarizing blockers. With competitive blockade, the muscle does not respond to direct electrical stimulation. What are now the pharmacological actions of these non-depolarizing agents? We know that not all muscles are equally sensitive to blockade by competitive agents. And usually, the smallest and the rapidly contracting muscles are those of the face, of the eye, and they are the most susceptible muscle to be contracted, to be sensitive. And they are paralyzed first, followed by the muscle related for the fingers, for our limbs, the neck, and the trunk muscles. The second muscles that are affected, those that are intercostal muscle. And lastly, the diaphragm. You know that the diaphragm is the muscle that separates the thoracic cage that contain the heart and the lung from the digestive system. The muscles, of course, because their blockade is competitive, they recover in the reverse manner. Regarding their pharmacokinetics, all neuromuscular blocking agents are given intravenously or occasionally intramuscularly. So usually they are not given orally. Why neuromuscular blockers are not given orally? Because these agents in their structure possess two or more quaternary amine in their ring structure that make them difficult to be absorbed from the gut. So they penetrate, in this case, the membrane very poorly. You know that a molecule which has two or more quaternary amine is a molecule that is more polar. And in this case, they cannot penetrate membranes usually. And they do not enter cells or cross the blood-brain barrier. Many of these drugs do not have metabolism, so they are not metabolized, and their actions are terminated by their redistribution. As you can see, the neuromuscular drugs usually they are minimally absorbed when they are given orally. That's why the better way to give them to the patient is by an intravenous injection. So some examples of neuromuscular drugs such as vicuronium and rocuronium and their metabolites appear mainly in the bile. So the bile will be then considered as their major route of elimination. And the other drugs that also belong to the NMB, neuromuscular blockers, are excreted primarily unchanged in urine. Another example, which is the pancuronium that is excreted unchanged without any metabolism in urine. The cisatracurium is degraded spontaneously in the plasma and by ester hydrolysis. And vicuronium and rocuronium are aminosteroid drugs. Those are the drugs that are metabolized in the liver by a process of deacetylation. So after being deacetylated, they are subject to pass into the bile to be eliminated. Note that their clearance or their elimination from the liver may be prolonged in patients, specifically in those with hepatic failure or hepatic disease. Like any other drugs, the neuromuscular blockers possess adverse effects, but in general, these effects are safe with a minimal side effect. If you look at this scheme, you will be finding in red the time to get a maximal blockade expressed in minute, and in yellow, the time to recover 25% of the maximal response expressed also in minute. If we take the example of atracurium, the atracurium exerts its function 2 minutes after its injection, while the time to recover 25% of this maximum response is about 40 minutes. Another example is with the cisatracurium. This drug will be exerting its maximum blockade 3 minutes after its injection. It reaches then the blood, where it is spontaneously degraded in the plasma, and it is the only non-depolarizing neuromuscular blockers whose dose need to be reduced, specifically in patients with renal failure, because the cisatracurium is one of the drugs using the urinary elimination. So it is often then used in patients with multi-system organ failure because its metabolism is independent of hepatic and renal function. Another example, which is the pancuronium. The pancuronium is a drug that can exert a vagolytic effect. And a vagolytic effect means an increase in the heart rate, thereby that is considered as a side effect.